specialty behavioral health is highly, highly stigmatized across the board, but more so with this age cohort. So most of them, most older adults will not seek their mental health treatment in a specialty, say, community mental health program, or go to a community-based psychiatrist as someone they'll go to first. They will first talk to their primary care provider. So integrating behavioral health into primary care, especially for older adults, becomes critical. In community dwelling older adults, it is as high as 20% of older adults experience depression and anxiety. And in nursing homes, it is even higher, as close to 50% of nursing home residents. So I would say the most common mental health diagnoses that older adults would present in a primary care setting would be depression and anxiety. However, I would also say that cognitive issues can also present frequently, comorbid, together with either depression or anxiety, or they could be due to their depression and anxiety. So having knowledge about cognitive screening tools would be essentials. What I have noticed in my 30 years of practice, very often older adults get very quickly misdiagnosed or with dementia. Because often when they present with depression in primary care, it's not your typical depression symptoms which are at the fore. It's really aches and pains. It's really memory and cognition problems. It's energy, lack of energy. So often they get misdiagnosed with dementia, and then obviously are not treated for the depression. And then it's a cascading effects on all their other medical diagnoses. Clinicians should have awareness about what are some tools used to screen for cognition. Two of the more commonly used ones now are called SLUMS, St. Louis University Cognitive Screen, and the MoCA, which is the Montreal Cognitive Assessment. And they are in the public domain. There are shorter screening tools than the MoCA and the SLUMS. One of them is called the clock drawing, and the other one is called the mini-cog, which are 2 minutes or less. The others have 30 questions. So if time is a factor, use some other the shorter version. So knowledge of screening tools is essential. Aside from that, it would be really what are some real treatment, what are some evidence-based treatments for older adults, especially in primary care settings. One of the ones that I would highly advocate is behavioral activation, which really is coming out of CBT, but it focuses primarily on behavioral activation, which has shown a lot of efficacy with older adults. And problem solving, PST, which again also comes out of CBT. But those would be the two that I would highly recommend. There are some manualized treatments for depression. One is called Impact, which is widely used. In fact, I think Minnesota, the state of Minnesota has adopted it, where they use problem solving and behavioral activation. So those would be the two. They're pretty short term, 6, but their efficacy is pretty powerful. I would also say education on medications and medication interaction would also be very critical. And with the wave of new baby boomers coming in, also screening regularly for substance use. The other would be the need for care coordination. I cannot tell you how often people have fallen through the crack or have had dire health outcomes because they have had multiple providers and nobody spoke to each other, or there was never an attempt made and one person didn't know what the other doctor was doing, with dire outcomes for the older adults. So I would really say those would be the two things. Get to know what the screening tools, especially for cognitions, are, because I think most people are screening for depression at this time, and really work on care coordination. The other big thing I have in general, whether it is, is really promoting health and wellness. So it's really prevention. And one of them is really looking at mitigating social isolation. So helping seniors or older adults who come into your clinic connect to socialization resources, because all the literature tells us that social engagement is protective against depression. I would say get to know your local, what we call APD, Aging and People with Disabilities, local office and case managers. So develop a close collaborative relationship with them. APD is part of Oregon's Department of Human Services, and they are the folks who provide in-home care. They are the folks who have the ability to see whether someone is eligible for long-term care services. So get to know your local APD partners well. They have case managers. They have transition coordinators. So get to know them. The second resource, which I think would be very, very helpful, is the ADRC, Aging and Disability Resource Center. These centers are regionalized, so there are 9 of them across Oregon, and they have a great website. I mean, the clinician can just put in ADRC and it'll pop up, and it gives you resources. You can customize resources right down to your city or your county. So I would say get to know your ADRC, get to know the staff. They have an information and referral person there, so get to know them. And then I'm hoping that that clinicians at primary care will also get to know the older adult behavioral health specialists. There are 24 of them across Oregon, in almost every county. Some counties have, some of them have been regionalized. Get to know them, because part of their task is to promote collaboration and coordination, and actually provide a platform for complex case coordination. So those 3 would be critical. I would also throw in get to know your senior centers. Each community has, a number of senior centers, many of them funded through the Older American Act. They can be very useful too in helping people get connected to resources. What I hear over and over again, one of the big barriers is also transportation. So get to know your transportation resources. What are your resources in your community? Both Medicare and Medicaid have specific billing codes for coordination of care. And as you know, older adults have not just one chronic illness, many have 2, 3, 4. And so coordination of care becomes critical. And so there are specific billing codes that can be used. We want clinicians of all types in primary care to be aware that this is a billable service and a critical service in terms of the long-term quality of life of older adults. And I would certainly urge them to seek technical assistance to become aware of what those billing codes are, because they are there and they're highly underutilized.